Good evening, everyone. Again, this week we'll be continuing our lecture series on one drug every week, and this week we're going to discuss antihistamines in dermatology. Now, antihistamines are one of the important classes of drugs that we regularly use. Actually, I think this is one of the most commonly used drug classes ever for a dermatologist. So you have a lot of dependency on these drugs, and you must have thought of once that nearly all antihistamines have similar efficacy in action, whether you use desloratadine or loratadine or cetirizine or belastin for that matter. Then is are they interchangeable? Can you change or can you replace one type of antihistamine with another type of antihistamine? Can you mix up antihistamines, or should you just keep on increasing the dose to 4 times the normal dosing to get the efficacy? So we'll just go through this and we'll realize how we can better use antihistamine, one of those drug classes which is significantly and very commonly used by us, and most of the time we are not very well sure about where and when to use which kind of antihistamines. Okay, for example, if a person who is engaged in activity which requires him to be very attentive, like a driver or a person who operates a crane, you need him to be very attentive. You cannot use a sedative antihistamine. Okay, but you'll have to realize that the different type of antihistamine have slightly different efficacy, slightly different pharmacokinetics, slightly different side effect profile, dosages. So we'll just go through little by little, and this week we'll just tackle first generation antihistamine. Next week we'll cover the second generation of antihistamines, and maybe the third also, and last we'll do a third video also, which will discuss all the other aspects which are left. Okay, so we'll decide upon that. So with that, without any other further changes, we'll start discussing the first generation antihistamines in dermatology. Now, what are antihistamines? Antihistamines are ethers which are based on imidazole ring of histamine. So you have histamine and it has a ring structure. So I'll show you the structure in the next slide. It has a ring structure, and the modification of the imidazole ring, when it leads to formation of different ethers, you have antihistamines. Okay, first antihistamine to ever made was mepyramine. So this could be a very good quiz question, mepyramine. And subsequently, the congener of mepyramine, that means the another drug which was formed from mepyramine, was diphenhydramine. And diphenhydramine was the first FDA approved antihistamine in 1946. Okay, so the first FDA approved antihistamine is diphenhydramine. Now, furthermore, when further newer and newer drugs were being formulated, the congeners were made by the modification of the side chain of imidazole ring. So you have an imidazole ring, and then you have a side chain attached to it. Okay, so modifications of this side chain led to different half-lives, different blood-brain barrier penetration, different side effect profiles. And so congeners, that means the newer drugs which are being formed by the modification of diphenhydramine, was because of modification of the side chain of the imidazole ring. Now, H2 antihistamine, or the antihistamine which act on the H2 receptors, were made by modifications to alter the imidazole ring. Okay, so this is the imidazole ring. So if you modify the side chain, you will get the H1 antihistamine. If you modify the imidazole ring, you will get H2 antihistamine. So we'll discuss in subsequent slide that there are 4 types of histamine receptors: 1, 2, 3, 4. For us, the H1 receptor is the most important, followed by the H2 receptors, and we will rarely come into dealings with the H3 and H4 receptor. Okay, so H1 receptor majorly, followed by H2 receptor. So if you modify the side chain of imidazole ring, you have H1 antihistamines, and if you modify the imidazole ring, you have H2 antihistamines. Okay, let's move forward. So before understanding antihistamine, we must understand what exactly is histamine. So we'll have a short introduction, a short discussion about histamine. Okay. So histamine was discovered in 1907. Yeah, 1907, and it comes from the class of chemicals known as autocoids. So what are autocoids? Autocoids are those chemicals, those chemical messengers which act on the secreting cell and on the cells around it. And autocoids include serotonin, prostaglandins, leukotrienes, endogenous peptides like endorphins, cytokines. Okay, so these are cell to cell messengers which work or act in cells present in the milieu, in the environment. Okay, so histamine is an important mediator of immediate allergic reactions such as urticaria and inflammatory reactions, immune functions, and chemotaxis of white blood cells. Now this statement is very important. Most important function of histamine is urticaria, which is one of the most important indication for antihistamine. But additional effects have also been seen on inflammatory reaction. Okay, so on inflammatory reaction, particularly pertaining to chemotaxis of inflammatory cells. Okay, so if you have action on the migration of immune cells, that migration is mediated by multiple different factors, histamine being one of them. Clear? So many chemicals we have already studied in different a lot of videos that we have covered before. We have studied these different mediators which are responsible for chemotaxis or migration of inflammatory cells from peripheral blood to the site of action. Histamine is one of them. So the major action is as a mediator of immediate allergic reaction like urticaria or inflammatory reactions or migration of immune cells. So these are the two major areas of action for histamine. It has a modest role in anaphylaxis. In anaphylaxis, the inflammatory reaction is severe. So a lot of other peptides, other mediators are involved. Okay. Other function is gastric acid secretion. Now gastric acid secretion is mainly by enterochromaffin cells. Okay, so these are not important for us. These are more important for, of course, gastrologists. But let's say you have a person who comes to you with urticaria who is also suffering from GERD. It's better to combine an H2 antihistamine in the regimen. Okay, so H2 antihistamine work better on gastric acid secretion, while H1 has minimal to no role or very less role on gastric acid secretion. So if you have a person who's suffering from gastric acid reflux and urticaria or any other indication for antihistamine, it's better to add H2 antihistamine to the regimen. Last is histamine also works as a neurotransmitter and neuromodulator. Now histamine goes inside the brain and it acts as a stimulant. So when you use antihistamine, this action of histamine is not there, and that is why you have sedation with antihistamine. Okay, so you have increased sleepiness with antihistamine because histamine as itself is a neurotransmitter, a neuromodulator. When it goes inside the brain, it works as a stimulant. Okay, let's move ahead. Now histamine is made by the conversion of L-histidine, which is an amino acid. It's an amino acid, and L-histidine gets converted by the enzyme histidine decarboxylase into histamine. Okay, so histamine is made from L-histidine by the action of histidine decarboxylase. Okay, histamine is rapidly metabolized and inactivated. Remember that histamine comes from a class of drug autocoids. So when a cell, so you have a cell here and it has a lot of histamine granule. Let's just say it's a mast cell. Okay, so a cell with lot of histamine granule will secrete histamine, and histamine is going to act in this self cell, the same cell which is secreted, and the other cells which are around. So if this is a cell, it secretes histamine. So all other cells in the vicinity will be acted upon by histamine. Okay, so autocoids. So when a chemical is rapidly metabolized and inactivated, of course the area of action would be limited. It won't be that widespread. Okay. Now it is stored as granules in mast cells and basophils. Now two important cell types are mast cells and basophils. Now these cells store histamine inside granules in their cytoplasm. So these cells have granules in the cytoplasm. Inside those granules is histamine. So here is the structure of histamine, and here is the imidazole ring. So this is the imidazole ring. Modification of this ring gives you H2 antihistamine, H2 antihistamine, while this gives the modification of this side chain gives you H1 antihistamine. Okay, so this is, and further a different modification of these side chains gives you different antihistamine. So we have understood about the physical properties of histamine. Now we'll see how it is secreted. Okay, so there are two methods which lead to histamine secretion. One is immunological, the second one is chemical or physical. Or you can say there are three methods: immunological, chemical, physical. Okay, so we'll be discussing the immunological one in this slide. So let me remove this. Yeah. So immunological. Most important pathophysiological mechanism of mast cell and basophil histamine release. So immunological method or the immunological process is the most important mechanism by which mast cells and basophil release histamine. Okay, so I've already told you in the last slide that there are two cell lineages or cell bodies, mast cells and basophils. These cells have histamine inside their granules, and upon activation they will secrete those granules and histamine. And the most important mechanism of the most important mechanism that leads to that secretion is immunological. Okay, so predominantly that is carried out by IgE antibodies. So IgE antibodies attaches itself to surface membrane, and because of that attachment leads to multiple secondary messengers which gives the signal of degranulation. So the process is known as degranulation. This is the process by which mast cells release histamine outside their cell. Degranulation. And in the case of type 1 immune reaction, or you could say the immediate type of reaction, that is known as explosive degranulation. So that is known as explosive degranulation. Now what do we mean by that? Explosive degranulation means that there is such a rapid degranulation, such very fast degranulation, that there is a sudden spike in the histamine concentration. Okay, and these granules have, along with histamine, ATP and other mediators. Okay, so ATP is also one of those itching and vasodilatory mediator also. Okay, now this process is the one which is used in immediate type 1 allergic reaction. So type 1 allergic reaction is based on the immunological release of histamine. Okay, so by the immunological release of histamine you have the type 1 allergic reaction. Now there is also a negative feedback in its own release. Remember, histamine is an autocoid. It will act on the same cell in which it is secreted, and because of that there is a negative feedback. So what happens is, negative feedback means it's a signal to the self cell. It's a signal to the same cell who has secreted histamine that we should also start to limit the secretion of histamine. Clear? So let me repeat it again. So let's say I am a mast cell and I receive a signal from IgE antibodies, and IgE antibodies telling me that I have to explosively degranulate. I mean, whatever that means. So after explosive degranulation, I release a lot of histamine, and that lot of histamine will have a negative feedback on me to limit the secretion of histamine, and that is why you have a spike of histamine, a sudden spike of histamine, because here is explosive degranulation, and then there is a negative loop which decreases it. Clear? So that is how histamine spike or histamine secretion happens. And this negative feedback is mediated through H2 receptors. So in the subsequent slide, we'll be looking at different type of receptors of histamine. So we have H1, 2, 3, and 4 receptors. So this negative feedback is mediated by the H2 receptors. Okay. So in case of any injury to the site, now this is very important in disorders like dermographic urticaria, or let's say papular urticaria, or insect bite hypersensitivity reaction. So this becomes a bit more. These points become very important in that context. So whenever there's an injury, there's a local vasodilation and leakage of plasma containing mediators of acute inflammation, which is complement and C-reactive protein, along with a lot of antibodies. Okay, so what happens is, remember that histamine is also a vasodilator. So what happens is that if you have a blood vessel which is lined by the endothelial cell, when it dilates, it will lead to leakage of plasma proteins, fluid, C-reactive protein, complement mediators, other inflammatory mediators. So what happens is, histamine is a vasodilator and also an chemical which increases the blood vessel permeability. And that is what you see as wheals in urticaria. Okay, you have a localized swelling of the dermis, and why is that happening? Because of histamine, the dermal blood vessels are now increasingly permeable, and because of their increased permeability, you have leakage of plasma protein and fluids outside the blood vessel inside the dermis, and that is how you have that wheal formation. Histamine also has an active chemotactic attraction. So what is active chemotactic attraction? Means it actively gives signal for the attraction of different inflammatory cells. So it attracts neutrophils, it attracts eosinophils, basophils, monocytes, and lymphocytes at the site of injury. So whenever you remember that you have anytime whenever you have injury, the area gets red, area gets inflamed, area gets warmer, the blood vessels are increasingly permeable at that area. So one of the mediators for this action is histamine. Now, the histamine inhibits the release of lysosome contents and several T and B lymphocyte functions through H2 and H4 receptor. This is just a statement that you should just keep in mind. Remember that in the last slide we discussed that histamine has a negative feedback on the secretory cell, and that negative feedback is carried on by H2 receptors. So similarly, histamine also has a negative control feedback over several T and B lymphocyte functions, and that is primarily mediated by H2 and H4 receptors. Okay. Histamine also leads to release of peptides from the nerves in response to inflammation, and that is mediated by H3 receptors. So let's just say that you have a synapse and a lot of mediators like acetylcholine, for example, let's say acetylcholine or adrenaline. Histamine leads to release of these neurotransmitters, and this release is mediated by the H3 receptors. Okay, so when you use antihistamine, the level of acetylcholine is decreased, and this leads to the anticholinergic side effects of antihistamine. So let me just recapitulate. Let me give you a summary what is happening here right now. So what happens is, whenever there's an injury, there will be a localized vasodilation. The blood vessel will get dilated, and that will lead to increased permeability of cells. And from that increased permeability, there will be chemotaxis of inflammatory cells like neutrophils, basophils, eosinophils, lymphocytes. Okay, so what histamine is doing? It is dilating the blood vessel after the injury. It is increasing the blood vessel permeability. It is calling all the inflammatory cells. Okay, and also from the nerve endings, it is secreting inflammatory mediators, which may include acetylcholine and adrenaline. And that is why when you block this H3 action of histamine by using antihistamine, all different kinds of antihistamine have a certain anticholinergic effect also, responsible for different type of side effects. Clear? Let's move forward. Now this is the second and the third method, the chemical and the mechanical trigger for histamine release. So certain amines like morphine or tubocurarine, or in fact just sodium ions in the extracellular fluid, can displace histamine from its bound form. Now remember that you have a mast cell. Okay, you have a mast cell and a lot of histamine in the granules, and that is known as bound histamine. So certain amines like morphine or tubocurarine have an ability to convert this bound histamine into unbound histamine, and when unbound histamine happens, this histamine gets secreted out of the mast cells and then it becomes unbound histamine. Okay, clear? This process is not explosive. So remember that immunological mediated histamine release, let me write it again, immunologically mediated histamine release is explosive, while this chemical or mechanical or physical mediated histamine release is non-explosive. Non-explosive. Clear? Since it is non-explosive, that means it is happening slowly. It doesn't require energy, no energy, while explosive requires energy. Let me just write it properly. So you have two methods of histamine release. You have the immunological one and you have non-immunological one. Non-immunological ones include chemical and mechanical. Clear? Immunological one has explosive degranulation. The non-immunological one has non-explosive degranulation. Immunological one requires energy. Non-immunological doesn't require energy. Immunological requires mast cell stimulation, while the non-immunological one does not require mast cell stimulation. Clear? So these are the methods by which histamine is released. Now let's see how it actually happens. So with this a little short animation, you will see that here I have a mast cell. So this is a, let me write it in black. So this is a mast cell. Okay. So you have a mast cell. I've made it like an fried egg appearance. That's what we see in histopathology. Okay. Mhm. So and these red spheres, these red circles are histamine containing granules, or you can just regard it as histamine. Okay. So here you have IgE antibodies. Here you have an antigen. Okay, when let's say you have a physical urticaria to certain antigen, or you have allergic rhinitis to an antigen, so this yellow star is just an antigen. And you have IgE antibodies, you have mast cells containing histamine. Okay, so these green areas are known as Fc epsilon R1 alpha receptors. These are actually a receptor for the Fc component. Okay, Fc component. Remember in the last IVIG video we talked about that an antibody has Fab and Fc component. If that antibody is IgE, this receptor is for the Fc component of IgE antibody. Okay, so it acts as a receptor for that. So let's move forward. So when an antigen attaches itself to the IgE antibody, the IgE antibody attaches to the receptor. So in this animation, when Fc epsilon R1 alpha receptor is activated by an activated IgE antibody, this is the first step, or you could say one method of histamine release. Okay. So when Fc epsilon R1 alpha receptor is activated by an IgE antibody against an antigen, that's one method. Second method is that you have IgG antibodies against IgE antibodies. Now these IgE antibodies are not activated like the first step. Okay, so in the first step you have an IgE antibody which gets activated by an antigen and then attached to the Fc receptor. In the second method, you have IgG antibody against IgE antibody, and whenever there are circulating IgE antibody, what happens is this IgG will attach itself to IgE antibodies, which activates this IgG antibody, and this activated IgG antibody will attach to the receptor. Okay, so in the first step, you have activated IgE attaching to receptor. In the second step, you have activated IgG attaching to receptor. And what activates IgG in the second step? That is IgE unactivated antibodies. This is the second step. Not second step, different method. There are three different methods to activate a mast cell. First method is by IgE, which is activated by an antigen. Second is IgG activated by IgE. Okay. The third is that IgE, without using any IgE, activates the receptor on its own. So this becomes the third step. So first step is IgE, second step is IgG mediated by IgE, and third step is alone IgE not requiring any kind of IgE. Okay, IgG not requiring IgE. If any of these three steps happen, there can be other steps also. There are multiple steps, but these are three most commonly implicated steps. Whenever any of these steps happen, all the histamine will get explosively degranulated. Okay, they will very rapidly leave the mast cell and go outside the cell to carry their function. So that is known as explosive degranulation. Clear? So let's move forward. Let's wipe everything. So these are the histamine receptors. So now we have learned what is histamine. We have learned what are the functions of histamine, how to activate histamine, and how does histamine get secreted from the mast cell. Okay, so these are histamine receptors. These are four receptors: H1, H2, H3, H4. For us, H1 is important, followed, let's put 2 stars, followed by a small star at H2. Okay, so the most important group that as dermatologists we encounter a lot in our practice is H1 receptor, and this receptor is present in smooth muscle, endothelium, and brain. So smooth muscles can be because of blood vessels, the muscles inside the walls of the blood vessels, endothelium, which is the cell lining the blood vessels, and brain. So presence on brain causes sedation when we use antihistamine. Okay, and endothelium causes, let me just write it again so that it is a bit less confusing. So presence of H1 receptor on smooth muscle leads to vasodilation. So blood vessel dilation. Action of H1 receptor on endothelium leads to increased permeability of blood vessel. Permeability. On brain, it's act as a stimulant. Clear? So that is how it acts. Post receptor, that is the secondary messengers, are G protein coupled receptors, inositol triphosphate, DAG, diacylglycerol. These are out of our discussion. Okay, and example of inhibitor is cetirizine. So the most important class that we'll deal with as antihistamines are concerned are H1 antihistamines, followed by H2 antihistamine, but predominantly H2 antihistamine are there in the gastric mucosa and cardiac muscle, also brain. Now remember that there are certain overlap of actions. If we use an H1 antihistamine, there is a little bit of action on the H2 receptor also, but the major action is always on H1. There's a little bit of action on H3 and H4 also, but majorly it's H1. So because of the presence of H2 receptor on the cardiac muscle, you have side effects like QTC prolongation, arrhythmias, which has been documented, or let's say it is mentioned in theory that these kind of side effects occur because of antihistamine, and that is because of the action of H2 receptors. Okay, so let's move forward. Okay, so we have discussed what is histamine, what are structural histamine, how does it get released from mast cells, what are the actions. Okay, now when we are discussing antihistamine, we'll be discussing the first generation, second generation, and third generation antihistamine. Now, initially, these antihistamine were thought of as histamine blockers. Histamine blockers, more like competitive blockers. So what happens is, let's say you have the surface of mast cell and you have a histamine receptor, and this is histamine. So normally histamine will attach to the receptor and it will lead to all the effects. Okay, what his antihistamine initially thought was, what they used to do, let's say this is an antihistamine, it will attach itself to the receptor and will block the histamine from attaching. So it will block histamine from attaching, and histamine will not be able to carry out its effect, and that's how antihistamine act. But nowadays they say that antihistamine are inverse agonist. So what do we mean by inverse agonist, and what is the difference between a blocker and an inverse agonist? A blocker means that it will attach itself to the receptor and will not allow the receptor to function. That is a blocker. Okay, remember your pharmacology MBBS third year, 2.5 years, second prof. Okay, a blocker is attaching itself to the receptor, not allowing the receptor to function. Inverse agonist is attaching itself to the receptor and allowing it to function, but the function is opposite to the initial molecule. That means when histamine attaches itself, it will lead to some function. When antihistamine attaches itself to the same receptor, the function will be opposite to the function of histamine. Am I clear? Am I making sense? That H1 antihistamine are inverse agonist of histamine. Inverse agonist meaning that they will attach to the same receptor, but the function would be opposite as that of histamine. Clear? So antihistamine has been divided. The H1 antihistamine has been divided into first generation, second generation, third generation. First generation include diphenhydramine, hydroxyzine, cyproheptadine, and ketotifen, which has a somewhat mast cell stabilizing action. Second generation include loratadine, cetirizine, epastin, belastin. And third generation include, from loratadine we get desloratadine, third generation. From terfenadine is now banned because of cardiac issues. We get fexofenadine as third generation, and from cetirizine we get levocetirizine. levocetirizine. Okay, multiple times you will see that fexofenadine, levocetirizine and desloratadine are second generation, because sometimes some authors would like to club second generation with third generation and have only two generation: the first generation, which are majorly sedating antihistamine, and second generation, which are less sedating antihistamine. Okay, so second and third can be combined together as second generation antihistamine. The first generation of antihistamine, which is the topic of this presentation, it took a lot of time coming to a topic, but we need to have a good understanding of the basics, is divided into 5 subclasses. You are not supposed to remember any of the subclasses. I'm just mentioning it just now. Ethanolamine, the prototype drug is diphenhydramine. You see it in Benadryl. Okay, just a brand name. Piperidine, which has cyproheptadine as a prototype antihistamine. Phenothiazine, which has promethazine as an antihistamine. Alkylamine, which is the chlorpheniramine maleate. Okay, chlorpheniramine maleate, which you see in Avil. And piperazine, which is hydroxyzine, and you know it by the name of Atrax. So these are all brand names. I'm just telling the brand names just so that we can have a understanding of drugs that we routinely use. Okay, so these are the 5 subclasses, and you're not supposed to remember any of them. Don't worry, just remember the names of representative antihistamine, that these are the antihistamine of first generation H1 antihistamine. Let's move forward. So the first generation of H1 antihistamine are lipophilic. That means they are fat soluble. They are non-polar molecules, fat soluble, and because of being increased in lipophilicity, increased fat solubility, they readily cross the blood-brain barrier. So you have a barrier, and here you have let's say brain. And what happens is, when antihistamine cross the brain, they will block on the receptor and cause a function opposite to that of histamine. And remember, in the first few slides I said that histamine acts as a stimulant. So these antihistamine will act as a non-stimulant, a depressive kind of molecule, and that is why you have sedation. Instead of stimulation, you have sedation. So this is responsible for the side effect of sedation. Clear? These are rapidly absorbed orally. The peak plasma level occurs in 2 hours. Metabolism is through liver by the cytochrome P450 enzyme. So remember, all the drugs which will increase the activity of cytochrome P450 will decrease the efficacy of H1 antihistamine, and all the drugs which will block cytochrome P450 will increase the efficacy of the action of antihistamine. The duration is 4 to 6 hours, but it has been found that the effect of antihistamine lasts more than 6 hours, so it may be prolonged. That is why a lot of urticaria patients are managed only a single daily dose or single alternate day dose. Okay, so it has been found that the action may be prolonged to more than 4 to 6 hours. They are reversible competitive binding to H1 receptor. We have discussed the binding of receptors in two slides before. They have negligible H2 action but a little H3 action. H2 action is responsible for your gastric acid secretion, HCl, while H3 action is responsible for neurotransmission. Let's just write neuromodulator. Okay. Additional action of H1 antihistamine are action on the muscarinic receptors, alpha adrenoreceptors, serotonin, and local anesthetic receptor site. Remember that nearly all antihistamine has a local anesthesia as an effect, but they are not used as local anesthesia because of local toxicity or local necrosis. So they are not used that commonly. So just remember that all antihistamine has a certain amount of anesthetic effect, but they are not as good as other anesthetic agents that we have. So we don't use antihistamine as anesthetic agents. Sedation. Now, the sedation with H1 antihistamine varies within drugs and within patient. What do we mean by that? That means a drug which does not cause sedation at lower doses will cause sedation at higher doses. That means it can cause when the doses increase. It also varies within patients. That means an antihistamine which is causing sedation to one patient may not cause sedation to other patient. Okay. So if a patient is having sedation, that doesn't mean that it will have sedation in the other all different patient also. And these are very important for second generation H1 antihistamine, because these second generation were made to decrease the sedative side effects of H1 antihistamine first generation. But you may still have sedation with the second generation one, okay, because it varies within patient. No abuse use is reported. So and there's one more thing, there's one word known as tachyphylaxis. Okay, so tachyphylaxis means tolerance. So many times the patient will ask, if I keep on taking this medication at this higher doses for such a prolonged time, would it happen that they will lose their efficacy? So that doesn't happen with antihistamine. There is no tachyphylaxis and no abuse is reported. So when a person is sedative, has sedation because of antihistamine and sleeping properly, the repeated use of antihistamine for that purpose will not lead to development of tolerance. However, paradoxical excitation may be seen, and that is seen in very high doses. High doses. So antihistamine in therapeutic doses will cause sedation. When the dose is extremely high, in case of toxicity, let's say a person has taken a lot of medication, or you prescribe 10 milligram and he has taken 20, you prescribe 5 milligram, he has taken 20 milligrams. Okay. So at very high toxic dose level, it can cause paradoxical excitation and can even lead to agitation, seizures, coma. So remember that this is one of the most serious side effects of antihistamine, but they do not occur at the doses that we use, especially if we titrate the doses as per age and weight. The other uses like anti-nausea and anti-emetic action, prevention not cure. That means if you take it before the setting up of motion sickness, it will be better. But if the motion sickness has already started, it has already set up, then it will not help. The drug that is mostly used is doxylamine. Anti-Parkinsonism effect. Remember the action of histamine as a neurotransmitter. Okay. This is mostly seen in diphenhydramine, significant acute suppressant effect on the extrapyramidal symptoms with a certain antipsychotic drugs. Now you don't have to get into deep that. Just remember that H1 antihistamine can have anti-Parkinson effects. Anti-muscarinic action. Remember that H1 antihistamine has a little bit of action on the muscarinic receptors. So that effect is seen. And that can present as non-allergic rhinorrhea. So they will be acting on the allergic rhinorrhea, but they can also cause non-allergic rhinorrhea. Urinary retention and blurred vision. So these kind of things can happen with antihistamine. Adrenoreceptor blocking actions. They have a significant alpha blocking effect, majorly by promethazine. So it can cause orthostatic hypotension. So tell your patients that when they want to get up from lying down position, they must put their legs, just sit for some time. Sit for some time on the bed and then slowly get up. If they get up too quickly, they can have attack of orthostatic hypotension. Serotonin blocking agents like cyproheptadine, which actually is used as an anti-serotonin agent. Now, local anesthesia. The sodium channels are blocked in anti-excitable membranes. Now, remember that histamine has an action on presynaptic vesicles, and it secretes a lot of neurotransmitters. So when antihistamine blocks this action, the sodium is not secreted in excitable membrane, and it can act as a local anesthesia. It stabilizes the membrane and the pain sensation is not carried by a nerve, because the nerve has lost that action potential generating event. So they can act as local anesthesia, but they are not routinely used as local anesthesia. Okay, and other action is that cetirizine inhibits the mast cell release also. So not only the action on histamine receptors are there, the action on secretion of histamine is also there. Adverse events include contraindications when there is hypersensitivity to the active drug, or you have to be very careful that they are not that routinely used in newborn or premature infants. They can have doses, so they can have side effects at lower doses also. In breastfeeding, in angle closure glaucoma, the first generation antihistamine are the only one which is implicated. Box warning include avoiding promethazine in children less than 2 years of age. Neurologic, you just have to remember these headings. So neurological, like Melinan syndrome, Cardiovascular, remember that heart has histamine H2 histamine receptors, so it can have ischemic heart disease, hypertension, because these make the patients more prone to arrhythmias. So use of antihistamine can increase the chance of arrhythmia. You have to be careful while using in thyroid dysfunction. Anticholinergic effects means that a patient suffering from benign prostatic hypertrophy can have increased urinary retention because of that. Okay, so make sure that you use it very carefully in BPH patient. You have increased ocular pressure leading to glaucoma. So remember that in patients with glaucoma or with BPH, you have to be a bit careful in glaucoma and BPH. Okay. Pregnancy categories are different for different antihistamines: cetirizine, diphenhydramine, doxepin, fexofenadine, hydroxyzine. So these are different. Just remember that cetirizine and diphenhydramine are these drugs have pregnancy category B, while some have C. But we'll discuss the individual drugs and I'll tell you what are the categories. Don't worry. So just remember the headings, and that is all you have to remember: the metabolic side effect, the respiratory side effect, and the anticholinergic effects. Okay. Now let's discuss very quickly individual agents. We will not spend much time. It will be very fast in this. First is hydroxyzine, which we know it by the name of Atarax. It's from the piperazine subclass. The doses are 10, 25, 50, 100 milligram tablet or a 10 milligram per 5 ml syrup. The pediatric dose is roughly about 0.6 mg per kg per day. So we should not exceed that, especially in newborn or premature infants. It has rapid gastrointestinal absorption and clinical effects are noted very fast within the first 15 to 30 minutes with hydroxyzine. Half-life is 3 hours, peak levels in about 2.5 hours, bioavailability 70%. Just remember that half-life is important, 3 hours half-life. In the body, hydroxyzine gets converted into cetirizine. So that's how it works. The first generation antihistamine is converted into a second generation antihistamine inside the body. It is excreted by the kidney, so kidney function should be good. It's a pregnancy category C. Okay, so hydroxyzine better to avoid. This is the structure of hydroxyzine. We can see the modification of the imidazole ring and the side chain modification, not the ring, the side chain modification. Okay. Uses are anxiety for symptomatic relief, psychoneurosis, pruritus. Now, usage of antihistamine to control pruritus and atopic dermatitis is a good question or a good thing to discuss. We will not discuss it today. It's a very detailed discussion whether antihistamine should be given in atopic dermatitis or not. But remember that itching in atopic dermatitis can have multiple factors, and the action of antihistamine in atopic dermatitis is majorly considered through its sedative effects. That means instead of blocking histamine, since it is going inside the brain and just calming you down, that is the important factor that controls itching in atopic dermatitis. So should you give antihistamine in atopic dermatitis or not? I give it personally, because if it is sedating, it helps. Some amount of itching is mediated by histamine. There are a lot of other mediators, but some is mediated by histamine. Let's give histamine. Number one. Number two, it also has a little bit of mast cell stabilizing action. So the other mediators are also not secreted that much. So it's better to give antihistamine, but don't go a lot of high doses 4 times a day. No, there's no needed. Consider topical or systemic steroids to control atopic dermatitis. Clear? As a sedative in pre-medication and following general anesthesia, just to sedate you down, calm you down. Okay. Precautionary side effects. Now, hydroxyzine potentiates barbiturates and narcotics, so you cannot take it or with any drug which can cause CNS depression, because hydroxyzine itself will cause a sedation. No driving or operation machinery. Okay. Drowsiness increases with alcohol. So these 3 points are very important. Drowsiness will increase with alcohol, and alcohol itself is a CNS depressant, can act as a stimulant in some way, but CNS depression. In geriatric population, if the kidneys are not functioning good, then the dose adjustment is required. Because of anticholinergic side effect, it causes dry mouth. It can even cause hallucination, headaches, and tremors. In skin, fixed drug eruption has been reported with hydroxyzine, and rarely it can cause urticaria. Overdosage can cause hypotension, excessive sedation, coma. How do you manage it? You manage it only symptomatically. Make sure the breathing is okay, everything is okay. Caffeine helps. You cannot use epinephrine. Why? Because epinephrine, the action of epinephrine is blocked by hydroxyzine. So if a person has taken a lot of hydroxyzine, no matter what epinephrine you will give, it won't be acting that efficaciously. So epinephrine should not be used. Just manage symptomatically, and caffeine. That's all. Okay. Coming to the second drug, diphenhydramine, it is from ethanolamine class. IV and IM formulation, that means a vial or an ampule is available. Oral are available, but it's better used as an IV or a IM preparation. Pediatric dose is roughly 5 mg per kg per day or 150 mg per meter square per day. Maximum dose is 300 mg per day for children, which can be increased to 400 mg per day for adults, which is divided into 4 doses. That means 300 divided into 4 doses or 400 divided into 4 doses. If you're giving it as an infusion, the infusion rate is 25 milligram per minute. It should not exceed. So infusion rate should be less than equal to 25 milligrams per minute. Okay. This is the structure of diphenhydramine. The T half is 4 hours, roughly around hydroxyzine. The peak level is 0.6 to 2.8, bioavailability 40 to 60%. It has a significant hepatic metabolism but minimal renal secretion. So this point is different. Remember, in hydroxyzine, we had a good amount of renal excretions that in geriatric population, we have to look at the kidneys before giving antihistamine. Okay, but diphenhydramine has minimal renal excretion but significant hepatic metabolism. So if a person has damaged kidneys but the liver is okay, you may consider diphenhydramine. Additionally, it is pregnancy category B, so that also helps. The uses are same as hydroxyzine. Some important point is it can be used with epinephrine. Remember that hydroxyzine was blocking the action of epinephrine. Diphenhydramine doesn't do that. So epinephrine can be used in cases of toxicity by diphenhydramine. Or let's say you need to use the epinephrine in a patient of, let's say, sepsis or something, and you still want to give some antihistamine for some reason, you may consider diphenhydramine. It's a good as an IV drug formulation. It is contraindicated in neonates and premature infants. And one important point is that IV injection can cause necrosis. So that is why do not use diphenhydramine IV or IM as a local anesthesia. It can cause necrosis. So it's one point, special point to keep in mind. Precautions are same as hydroxyzine. In skin, it can cause urticaria, drug rash, anaphylaxis. CVS can cause hypotension, headache, palpitations, tachycardia, all that. Blood hemolytic anemia has been reported, thrombocytopenia, agranulocytosis. Now remember, histamine has a good amount of chemotactic action. That means bringing the inflammatory cells. So antihistamine are going to block that action. So those inflammatory cells are not there, and that can lead to agranulocytosis. CNS like sedation, sleepiness, confusion can be there. Gastrointestinal can cause anorexia, nausea, vomiting. Genitourinary can have difficult urination, urinary retention, especially in patient of benign prostatic hypertrophy. Okay, so in older patients who don't have proper working prostate or any cause of urinary retention. Now remember, there's one point I would like to discuss here. These kind of drugs are used in patients who don't have a proper functioning bladder. Okay, it will lead to proper contraction of bladder. So if the urinary retention is because of an inactive urinary bladder, you may give that. But if the urinary retention is because of an outflow blockage, like we see in BPH, then these drugs will not be given. They will increase the urinary retention. Clear? So let's move forward. The third drug is chlorpheniramine. You know it as AVIL. In IV and IM, 1 ml is 22.75 milligram per ml. Okay. So in IV and IV, it is 22.75 milligram per ml. Oral comes at 25 or 50 milligram. You can go as high as 150 milligram a day. That means 50 milligram thrice a day doses is the highest, the ceiling dose. If you are using it as an infusion, that 1 ml per minute infusion is there. So in patients who are less than 12 years of age, it is advisable to give either IV infusion of chlorpheniramine or give an intramuscular single dose injection. That's much better rather than giving orally. It is not recommended in less than 5 years. Take it with food. Do not take it empty stomach. Okay. Do not. This is a warning which is there in the product insert. Okay. Do not take. Sorry. Do not take on empty stomach. Okay. You have to take it with food. Do not take it with alcohol. No alcohol. If you combine evil with alcohol, you will land up in serious trouble. Chlorpheniramine has a potential for abuse. Okay, people may take it to sleep, and it has a potential to being an abusive drug. Okay, or use it for abuse. So these are important points. You can go as high, give IV IM infusion, take with food, do not take with alcohol, and it has a potential for abuse. And this is a structure for chlorpheniramine. You can see the chlorine group from where it gets its name, chlorpheniramine. The T half is 15 to 25 hours for chlorpheniramine. It's the longest T half of any H1 antihistamine first generation. Okay, peak level occurs in 2 to 3.6. Bioavailability is 25 to 57%. It has a significant hepatic metabolism but renal excretion like all other drugs. It is pregnancy category B. So in any pregnant lady, it's better to give chlorpheniramine maleate. Okay. Additional point is that do not use chlorpheniramine with MAO inhibitors or atropine. Okay, these two drugs, because it can potentiate the anticholinergic effects. Potentiate it. See, MAO inhibitors and atropine are anticholinergic. So if they are given with chlorpheniramine, the anticholinergic effects is increased, and that may cause side effects. If there is an overdose, you manage it again symptomatically. If it happens early, let's say I've taken chlorpheniramine and the overdose has just started, then you can induce vomiting so that I may vomit out all the chlorpheniramine. But if there has been some time between the chlorpheniramine intake and the presentation at the hospital, it's better that vomiting should not be induced. Why? Because the patient is sedation. There's a chance there's a chance of aspiration of vomiters while you're inducing vomiting, and aspiration can lead to aspiration pneumonia, and that's a very serious side effect. So if during the initial stages patient comes to you, you can induce vomiting, but on later stages when sedation is started to come in, it's better not to induce vomiting. Better is to put a Ryle's tube and maybe gastric lavage. That is a much better option. Stimulants can precipitate convulsions, so do not give any stimulatory drug. Okay, if you give stimulants while the patient is suffering from chlorpheniramine overdosage, it can lead to convulsions. If there's increased cardiotoxicity or any arrhythmias which is happening because of chlorpheniramine, physostigmine is the drug of choice. So that is just a mention. I don't think so we'll ever require this information, but I've mentioned it. Now these are the H1 antihistamine side effects by the organ system, and this is a good article which highlights the antihistamine safety in geriatric population. So I'll put in the description, I'll put some articles, and this is one of them, and you can go through them if you want to learn about the safety and efficacy. I'll be not mentioning this slide because I've mentioned in detail while we were discussing different kind of side effects for antihistamine. Now these are few articles that I've gone through. All of these articles URL I'll put it in the description. You can just copy paste them and go and see what is the full text of these articles and read about it. Okay. Phew. So with that we have discussed first generation antihistamine. So just few points. Number one, antihistamines are the safest class of drugs that we deal with routinely. And why they are safest? Because we know about them, we use them a lot, so we can titrate it easily. So now you know which antihistamine to use when a patient's kidney is not functioning properly, which antihistamine to use when there's a lactating mother who requires antihistamine or a pregnant female who requires antihistamine. What dose is the highest dose available? What are the side effects you have to look forward to? What happens if a person has taken, let's say you prescribe 10 milligram hydroxyzine to a child and they take 25 milligram by mistake? Okay, or anything can happen, any kind of overdoses, you know what to do in that cases. But the most important point that I want to take from my presentation is the safety and the efficacy of antihistamine. Okay, so the antihistamines are safer in large doses. The guidelines mention to go as much as 4 times the daily dosage to control diseases like urticaria. Okay, but they're much more safer than that. There are theoretical risk of arrhythmias because of action on cardiac muscle, but I've yet to come across a patient who suffers from arrhythmia, maybe because ECGs are not routinely taken while you're giving antihistamine. But there are no clinical complaints. These are all risks which are mentioned in the product insert, so it's better to know about them rather than being afraid of them. You can combine H1 antihistamine first generation with second generation. There's no law or a rule that you can combine two antihistamine, but it is better to just updose or increase the frequency or doses of one antihistamine rather than using two different one, because it becomes easier for the patient to know. So if I have one tablet, if I am taking for 3 times a day and it's not helping, increasing it to 4 times a day is a better option than adding another different class of antihistamine. Okay. However, that being said, I do combine second generation antihistamine with first generation antihistamine when I am desiring sedation. When the itching is that severe that the person is not able to sleep, or I'm giving it when in children who might be very hyperactive or very irritated because of increased itching, it's better to give them a sedative antihistamine so that they can sleep peacefully. है ना? So that because good amount of sleep is responsible for a better healing process, so we need to take that into account also. But remember, do not give sedative antihistamine in a person who is responsible for driving cars or responsible for handling heavy machinery. I remember I once I once came across a patient who was a driver by profession, and he was suffering from urticaria, and he was prescribed hydroxyzine by some other doctor, general practitioner, and he never discussed the sedative potential of hydroxyzine. And the driver took hydroxyzine on long drive and had a severe sedation leading to a very you know severe accident, and he got multiple fractures and multiple rods in his hand and arms and legs because of that accident, just because he was not told that hydroxyzine can be sedative. So it's better that you always tell your patient that use it only 1 hour, 1.5 hours before you go to sleep, and do not operate any heavy machinery. Or it is better to prescribe them non-sedating or less sedating second generation antihistamine. So with that being said, we'll meet again next week. Next week we'll be discussing second generation antihistamine, and with that we'll cover our two-part lecture on antihistamine. I hope after that, before this lecture, of course, you were not having any issues with prescribing antihistamine, because we had no idea how they work. We had no idea about their side effects, but now you know. And since we know a lot more about antihistamine, it is now better for us to mix and match to prescribe antihistamine in different indication. Okay, so with that, I'll finish this presentation. I thank you for listening to such a long classes. Adios, bye bye, enjoy your weekend. Goodbye.